Hello, everyone, and welcome back to another episode of Real Conversations About Aging Parents. This is your host, Rebecca Tapia. Thank you so much for joining me. I'm looking forward to sharing a very interesting, maybe dry topic today, but hopefully is relevant and pragmatic for you, as I want all of our episodes to be. Before I get started, I did want to see if you are getting any value from this podcast. If you could please share the podcast with other people so we can continue to grow and reach more people, and hopefully they can learn from all of the lessons that we're learning here together from all the different aspects that we've talked about. And yeah, so we're heading up towards 100 podcasts. I can't believe it. Anyway, so I always like to draw my podcast from real life experiences. And the other day I was in a facility and I saw a patient, and I thought to myself, I thought that patient actually discharged last week, and maybe I'm crazy. Maybe something happened to them and they came back, or I don't know. I was really confused. And he was wearing street clothes, and I walked up to him and I said, "What? Are you okay? What's going on? Are you back?" And he said, No, I'm here trying to straighten out an issue with my medications. And I thought, okay, yeah. So, and to be fair, that's the first time I've seen that happen at that facility. And I'm not sure it was even an issue with the facility. It was just, I think, a miscommunication. But still, it reminded me that I think unless you've engaged heavily in the healthcare system or worked in various parts of the healthcare system, it might not be apparent that there are some gaps and inefficiencies. And I know that's not news to everybody, but I wanted to focus down on one of the most important vulnerabilities of moving through our healthcare system. And that is called transitions of care. Now, that's just like an umbrella term for any time somebody moves from one setting to the other. And that could be as simple as moving from an ICU to a general floor. That could be moving from a hospital setting into a rehab setting, and from a rehab setting into a skilled nursing setting, and or all the way down to the patient moving back home. And then you're looking at transition support with something like home health. And so transitions of care are really just broad-based terms that refer to basically a new care team, often a new physical setting. And anytime you can imagine that a patient undergoing a complex medical issue is with one team and they get to know you, and then 3 or 4 days later you switch to another team, and then you switch to another team, there's a lot of vulnerabilities that are introduced in that process. And I want to talk about this from a practical kind of what this nitty-gritty looks like. So I'm not talking so much about the front end of a healthcare experience. So if there's, say, somebody with chest pain while they're out having lunch with their friends and then they get into the hospital, I don't consider that so much a transition. That's like an emergency relocation of somebody to a setting where there's the right equipment and personnel to help them. This is much more kind of down the road and coming back. You think of it like a loop, like coming back into your life and all the transitions it takes to get back there. And so that patient may spend a couple days in the cardiac ICU. Maybe they have a procedure, and then they get moved down to the telemetry floor where they monitor their heart rate. And then there's a case manager that appears at some point and says, okay, where are you going to go? Like, where is this person going to go? Now, in an emergency situation, the hospital doesn't really get to ask, when you're coming in with chest pain, where do you go after this and who's going to take care of you? That's kind of relegated to the last, kind of sometimes a hot potato situation. The hot potato gets passed down to a case manager that's eventually going to have to figure out a transition of care. And so a lot of times patients will end up in a rehab setting, whether that's acute rehab or skilled rehab, because they've had a heart attack and they are recovering and they're not quite strong enough to go home and take a shower on their own or go up and down the stairs if their bedroom's on the second floor. And then that's where rehab really starts to come in as the next potential destination. And so then you might go from a hospital setting, like I said, into a rehab program. But eventually, if this person cycles back home, I want us to really kind of take that one little piece there and really drill down and understand what are some of the issues, especially if you're helping an aging parent and you're going to be on the receiving end, whether that parent lives with you or you've flown in to help with that transition, or you live nearby, or, you're the kid who's showing up and just the one that needs to kind of be involved. So ostensibly, something has happened to the patient that has made them incapacitated in some way. I mean, maybe not cognitively, but after you've been in the hospital, let's say for this case, say they've been in the hospital 7 to 10 days, they're not feeling great, right? They're probably haven't been sleeping well. Hospitals are horrible places to sleep. Maybe haven't been eating well because your appetite can be down when you're not feeling good. Oh, and by the way, hospital food's not so great. Oh, and by the way, being in the hospital is very disorienting, even for young people. And by the way, by the time you've been there 7 to 10 days, you're not feeling at your best and you're not asking really sharp, pointed questions that are going to help your transition. And so one of the key areas, if you are supporting an aging parent, to really, if you had to think of, I've got to go into fourth gear here, that is a transition home. And let's talk about why that can be so important. First, I want to talk about medications. When that person left the lunch with their friends and arrived in the emergency room, the doctors there had no way of knowing what home medications that patient was on. The only exception to that is one, if that patient had very recently been in that hospital system before, maybe they're seen at a clinic that's attached to that hospital system. And so they open up the medical records and voila, it's all there. Two, maybe the patient in extreme chest pain happened to have a list of medications in their purse or their a bag or whatever. That's extremely unusual, right? Three, maybe a family member who showed up that day or later that day happened to also bring a list of medications with them. That's unlikely, right? Because it's not like you're walking around with a list of medications in your pocket. So most of the time, at least in the first 24 hours after an emergency event, the only thing that that patient is on is emergency medications. So that could be something like a heart rhythm drug. It could be a blood pressure drug, could be a blood thinner. But in the moment, nobody is thinking, oh, we've really got to go make sure that they're on their Cymbalta or their Zyrtec or whatever. That is not necessarily the focus. The focus is to stabilize that patient and obviously avoid the mortality risk associated with the heart attack. And they're not so much focusing on the home medications. And so you can start to see that there's a breakdown, right? Because we don't have a universal record system. Now, if you remember, okay, probably you don't. I don't know why you would remember this, but there was a push a long time ago, like back in, I want to say maybe 2007 to 2008, ahead of the Affordable Care Act coming out. And there was a thought that we could somehow coordinate or incentivize all clinics and hospitals in the country to get on the same medical record system, or at least have a back-end sharing of medical records. And lo and behold, it's 2025, and that actually is impossible. Not only did it prove to be impossible, but even the Department of Defense and the VA, which all of the VA patients at one point belonged to the Department of Defense, don't share a medical record. And I got to see some of the efforts to kind of share on a website on the back end, but it was not what you would call like a fully integrated, easily accessible shared medical record. And that was literally a system set up by the federal government. So the push for universal medical records actually started in 2004 under President George W. Bush. And the goal was that every American would have like basically a shareable electronic health record within 10 years, so 2014. So they actually set up an office of the National Coordinator for Health Information Technology, which that must have been like an awesome dinner party to go to. But yeah, their Christmas party must have been really fun. Anyway, and so come 2009, there was an act called the American Recovery and Reinvestment Act that came right after the Great Recession started in 2008. And part of that act was something called the High Tech Act, and that's Health Information Technology for Economic and Clinical Health. And that invested $30 billion to help the United States adopt basically electronic health records as opposed to the paper records that you've seen, back in the day. Although I know a lot of doctors that still use paper records. But anyway, so they decided that they were going to first incentivize the uptake of electronic records and then later punish the lack of uptake of electronic health records. But anyway, interoperability, which was like, okay, now everybody has health records. How are we going to possibly get everybody to have back-end access? So no matter what hospital or clinic you're going to, somebody could access critical records, which would be maybe medications, allergies, medical diagnoses, surgeries, etc. And so in 2015, there was some publications that talked about basically portable digital health records and how the different records could operate with each other. But it just never really happened. Actually, very hard to enforce. There was lots of different companies that did different kinds of records. And that could be a whole other podcast. But basically, That did not take off. And so we are still stuck with extremely fragmented medical records unless you literally have all of your providers in the same umbrella. They all use the same medical record under the same company. So like for here, one hospital may use Epic, which is an electronic medical record, and the hospital down the street may use Epic. But if those are two different hospital systems, those Epic systems don't talk to each other because Epic is the software bought by the hospital for their records and is not meant to share information on the background. And then, of course, there's all this privacy issues and data sharing. Anyway, I'm getting way off course here. The point is, as somebody has shown up to the emergency room, unless there's these other weird circumstances, nobody really knows, right? And so medications really don't pop up until after the critical phase. And even then, you're sort of asking the patient, and the patient doesn't have a list or can't come up with something. Then you're asking family members to come in and produce a list so we can make sure if there was something that would be, hard to discontinue. For example, venlafaxine or Effexor is a medication commonly used for pain, anxiety, depression. And that particular medication, if you don't take it for 2 or 3 days, you'll have a pretty significant withdrawal syndrome, not life-threatening, but very symptomatic. And so, again, it's not considered a drug that is so critical you would, immediately have to put it on during an emergency. But like, it's important to know, hey, wait a minute, this patient's been off this medication for quite some time. Maybe that's why they're having some of these symptoms. And so speaking of just the medication portion of this, and for practical purposes, this is where I think a lot of the issues occur, is technically when that patient leaves the hospital system, they're supposed to perform what's called a medication reconciliation. So that means that a medical person, maybe a doctor, maybe a nurse, maybe both of them, take the list that somebody supplied as the home medication list. So think of that as the original set of medications. And then they say, well, we've now had this heart attack, so they need to take more of this drug, less of this drug, stop this drug altogether, start this new drug. There's actually 4 different options, right? Start, stop, increase, or decrease. And so they have to go through each medication and actually report, okay, I'm going to start this medication, stop, etc. And there's kind of an art to it, by the way. I mean, I know it should be really straightforward, but there's always a lot of question about whether or not the patient was really taking that, especially if they're a poor historian and they weren't sure. And then in the context of the new issues, and then who's going to manage these medications. But anyway, so at the end of the hospital stay, there should be issued to the patient a discharge summary. And for the vast majority of hospital stays, this is still true, that they're still getting a basically printed out discharge summary at basically the day that they go home. The problem is the chances that whatever's on that discharge summary has been discussed with the patient or their family prior to the minute that it's literally produced in this packet is usually very low. And so if you're thinking that somebody's going to discharge in the next day or two, like and I'm not trying to diss on any particular part of the healthcare system, it's just really busy. And sometimes the doctors don't know until the day of discharge, am I going to continue this antibiotic or not? I'm going to go look at the culture reports this morning and decide they need 10 more days or maybe 5 more days. And so they don't tend to produce these types of documents too early because they could contain errors. And so a lot of the time you have a new complicated hospital stay, and like literally as the person is almost walking out the door, there's this, okay, here's this list of all the different medication changes. And that's okay. That's step 1. That's just to know what was changed. It doesn't necessarily say why. And so, and I've read a lot of discharge summaries in my life, probably thousands of discharge summaries. And depending on the electronic medical record system and just depending on a couple other factors, you could end up with, say, 5 to 7 medication changes and not really quite understand why this one was stopped and why this one was started and so forth. Now, you can hope to go through the rest of the medical record, maybe the last physician note, and try to infer from that, like, why these medications have changed. But I'd say 95% of the time, the documentation that you're leaving with when you leave a hospital does not actually contain a physician note. And so that's really critical. Like, the information that's actually contained in these packets that are provided to patients from a medical perspective is fairly limited. It's like, here's your diagnosis, and it will just say pneumonia or heart attack, which we would call a myocardial infarction or MI. do this, not that, follow up here, and then 75 pages of just general instructions about diet and exercise and not smoking and stuff. And so, the meat of a discharge summary is actually kind of hard to find. And I'm very adept at looking at these, and sometimes I still have to search, really go line by line to find the information I want because it's buried amongst pages and pages and pages of other kind of, I would say, fluff documentation. Maybe not fluff. I mean, education's important, but I don't know many patients who have gone home and actually read through their discharge summaries, but there's a few. There's some out there. But anyway, so that's just step one, is actually having documentation of what was started and stopped. The next step, right, is where am I going to get these medications? And that is even variable. Again, usually not discussed ahead of time unless you're proactively asking and saying, okay, well, now I have these new medications. Well, who's going to prescribe them? And how am I actually going to get them? And so one option is they just hand you a set of paper prescriptions, right? Okay, so say dad's getting discharged on Thursday at 5 p.m. and they're like, okay, well, we're going to give you 30 days of prescriptions. Some will only give you 7. Some will give you 14. So somewhere between 7 and 30 days worth of prescriptions, and they'll hand you a paper prescription. Well, there's an issue there, right? Because if the pharmacy you use, especially if you're in a small town, closes at 5, then you're not getting medications that night, and you're probably not getting medications. You're missing the morning doses as well, because the best case scenario is you go over and drop off the paper prescriptions that next morning and maybe get them by the afternoon. So you're going to go probably 24 hours at a minimum without those medications if it's a paper prescription. Some hospitals will send them via e-scripts, which just means that they are connected to the pharmacy, assuming the pharmacy also participates in those types of systems, and can send them electronically. As you know, if you've ever dealt with a pharmacy, it can be really hard to know which ones were sent, which ones were ready, how much do they cost. And I say that because during the hospital stay, and if the physicians are ordering new heart medications, I can pretty much tell you they're not looking at the patient's drug coverage through Medicare Part D or their commercial insurance and thinking, well, I'm going to pick, if I had option A versus option B, well, option B is tier 1 on their healthcare plan, and option A is tier 2. That it doesn't happen like that, right? They make a recommendation in the hospital setting. There isn't pre-authorization for medications. They just kind of move through, right? So you may have all of the prescriptions either in your hand or maybe they were sent to the pharmacy, but you might have a little bomb in there, right? There might be a drug in there that with your insurance coverage or your aging parents' insurance coverage is, I don't know, $1,500 a month or something. So you get a little surprise there. So that's another pitfall because, again, they're not necessarily running those medications through your outpatient pharmacy coverage. So that's another one. Another one, this actually happened with my grandmother, and I would say with extremely proactive planning, and it still happened to us. And that was while she was in the ICU. This happened last summer. You can go back and listen to all those episodes. It was a little crazy. Anyway, while she was in the ICU, a palliative care doctor came and placed her on morphine. And, she was in a lot of pain. She already had chronic pain, and then she had this bleeding stomach ulcer and this head injury. And he put her on morphine. That was something he recommended, and that stayed with her through her hospital stay. And she ended up going into rehab. Now, rehab was located at the same hospital, so that was nice. All the medications transferred. But when she was discharged from the rehab system, there was nobody that was going to write the morphine prescription. And this is not coming from a drug-seeking person or a drug-seeking family. It was just, they just weren't going to do it. And so I know my mom called the doctor who had prescribed it and had said, and we asked that actually the day it was prescribed, I asked him that. And I remember standing next to him saying, okay, if that's the recommendation, I get it. And, maybe we're heading more towards a palliative hospice route anyway, but like, who's going to manage that medication? And he said something like, oh, don't worry, just call my case manager, we'll get you enrolled in our palliative program. And guess what? After multiple attempts to get in touch with this person and leave voicemails and so forth after the fact, there was not a real route. It was like an imaginary bridge to the future that didn't actually exist. And so, again, that's a physician talking to another physician, specifically worrying about this outcome, and then the outcome still comes true. So if it's happening to you, don't worry. It's not like even in the best of circumstances that this is avoidable. And so anyway, we're released from the hospital, and like she doesn't have this medication. And I know my mom and I and like other people joined this effort to try to find a doctor that would actually prescribe this, and it was actually impossible. Just didn't happen. The pain doctor wanted her to physically come into clinic, which was not possible in her condition. It would have been it would have been an ambulance ride both ways. That was not going to happen. Then the palliative care doctor was like, "Oh no, we don't do morphine. I think we're going to have to switch over to hydrocodone or something," which is what she was on before. Primary care wouldn't touch it. It became like this weird, well, we didn't necessarily press for this drug. So she ended up being just taken off of it. And thankfully, she actually did okay. I'm not sure the morphine was doing much for her. Maybe it was even adding to her confusion. But I go back to like, why was this so hard? And not just with controlled substances, but there are just, you can think about, pain medications, anxiety medications, some of the sleep medications. Doctors are under such heavy punitive measures for prescribing these medications outside of very, very strict prescriptive, processes. Understandably, like you can imagine why, but like it's the pendulum has swung where it's actually nearly impossible unless you're in a hospice type setting to get some of these medications. So I would be of course, to do lesson learned, right? Unless there was a hospice situation, I would be very much against somebody being put on narcotics that are not going to be supported in the outpatient world. Now, maybe for a temporary time, sure, like postoperatively for a couple of days, but this was her new long-term pain management. And it's so stressful because calling people, and there's obviously this cloud of, well, why does she need morphine and what does she want more? I'm like, nobody wanted the morphine. I'm just saying once you're on it, you have to be titrated off of it. And it just kind of ended up like a debacle. And to this day, even the narcotics she's on, we're kind of on a month to month with her palliative doctor. I don't know. It's the weirdest thing. Like and she's about to be 92 and, she can't make it to the pain doctor anymore. She can't make it to her primary care physician anymore. So she's kind of part of this home health palliative team. And even then it's been kind of challenging. And so anyway, I'm venting. But the point is not getting just the paper of the discharge medications is always enough, right? You have the issue of the pharmacy availability, and God forbid there's a shortage of that drug, which that's been happening a lot the last several years, and then the cost of the drug and then actually getting it. So these are very different worlds. And I will tell you that these pharmacy issues occupy a lot of frustrating time because the systems don't necessarily talk to each other, right? And you kind of, once you leave the hospital, trust me, like you are not really part of them anymore. And getting somebody to respond to you and help you navigate that, what you're going to hear from them. And I don't mean to speak for hospitals, all right? I'm not trying to paint a broad brush, but you don't belong to them anymore. So you're going to call them, and there you have two options with these medications. All right, sir, well, you can go see your primary care doctor, which maybe your primary care doctor's next appointment is in 2 months, right? Or you can come back to the emergency room. And that is actually one of the reasons people go to an emergency room is they don't have access to the medications that they were theoretically just prescribed from that same hospital. So they go back there and then they get, say, a 7-day supply, or they get a different medication. There's some troubleshooting done. But geez, that's an expensive and time-consuming and very draining way to go back and fix this. And so one of the better strategies is the hospital will always recommend that you see your primary care physician within 7 to 10 days of that discharge. So a lot of them will only give you 7 days to sort of incentivize you to go ahead and go to your primary care physician. But of course, now you have somebody who is just sick. And so you want to hope they feel good enough to go to the doctor that day, or you're going to drag them there. You also hope that the doctor shows up that day and doesn't have some issue. And then you get rescheduled, 2 months out or something. And then, sorry, this is really going to be like, I'm not trying to make you worried. I'm maybe laying out the worst case scenarios. The other issue is you're also assuming that once you get to the primary care doctor, that they are comfortable in refilling all of those new medications. And there is sort of this unspoken culture of the person that's maybe, discharging them as a physician isn't necessarily all that worried about the primary care doc on the other end of this. There is always this thought, I'm speaking too broadly. There's sometimes a thought that somebody else is just going to have to figure this out, right? They're going to have to dig deep into the insurance issues and the pharmacy availabilities, and that's just not the role of an inpatient setting. And so you might get all the way to that primary care appointment and be like, oh my God, I didn't realize that this doctor won't refill this medication, or this doctor might feel like this medication is outside of their scope, meaning, hey, like an example would be anti-seizure medications, right? So a lot of primary care physicians are not so keen on just continuing anti-seizure medications. They might say, okay, well, you got to go see a neurologist, and then the neurologist will manage those, and I'll give you refills to get to the neurologist, but I'm not managing this medication. The other thing that can happen because of the incomplete medical records in the first place is the primary care doctor might say, oh my God, how did you get on this medication? Didn't you know that you had this reaction 6 years ago? Or, hey, I'm noticing that there's a drug-drug interaction between this medication and this medication, or, hey, they've actually duplicated this or whatever. And so they kind of have to go in and be a sleuth and figure out exactly what's going on. Now, this is assuming, this is really negative, okay? Maybe I'm being a pessimist today. This is assuming that the doctor you're seeing has the actual time to go through this. And that's a whole other conversation, right? But most doctors are, allocating 10, maybe 15 minutes for these visits. And if you're lucky, maybe they put you on the schedule for 30, but because they probably only scheduled this 7 days ago, you're probably not getting a lot of time because they probably fit you in. In fact, my dad went to his post-hospital visit with his doctor, and she caught a lot of errors and a lot of things that needed following up that weren't noticed during the hospital stay. And he has this great doctor. She's the best. And she actually spent time going back through all of his records and said, hey, did you know about this finding on this MRI? Well, we need to do this. And oh, by the way, your kidney this and your liver that. So I'm really thankful he has her as a resource, but I know that that's maybe not the standard across the board. But if you do find a family physician or an internist or somebody that you really, really click well with, please do keep them as long as you can. They can be a really great resource. And they actually tend to obviously know that patient a lot more than the doctors that saw them in the hospital. And so anyway, so that is sort of the landmines. I have seen cases where if the patient is using home health services, when the nurses come out, they will assist with the medication reconciliation. And if there are issues, I have seen them be very effective at advocating and helping support the patient and trying to help figure some things out and get the medications in place. So that's a good resource along with the primary care physician. But just be prepared. I think there's a lot of assumptions that at that point, okay, well, the heart attack is in the rearview mirror and we're getting better and maybe we're going to do some rehab. And this medication thing can really come out of nowhere. And not only that, there is a whole other practical point of you're dealing with somebody who might have some cognitive issues, or maybe they're really tired and they go home and they have all the sets of the old medications in the same medication cabinet as all of the new medications. Then that can be confusing as well. So one thing that can be really helpful is to make sure that they're separated or removed or otherwise put away so that it's very clear that this is the new medications and the new pill boxes and that they're not mixing them up. And as you've noticed in some cases, even the same medication looks completely different. If it's from a different manufacturer, it can have a different color and a different shape. And so you don't want to rely on, oh, that's always the round orange pill or the green pill or something, because that can also be problematic and mixing and mashing too, and relying on how the medication looks as to knowing what it is. That's not usually the safest thing to do. So medications are just a big pitfall. If it goes great, then perfect. If there's very few changes, usually that's okay. But once you get into changing anywhere from, say, 3 to 7 medications at one time, that takes a lot of coordination and a lot of adaptation for the system to help get that done consistently. And a lot of times it's usually just that short transition period where they get everything resettled and the pill box is restocked and everybody's okay. But again, the major points are, how is this going to get refilled? Is the insurance going to cover it? And then long term is, if this is a new medication, now you're going to be on the lookout for side effects. So if it's a brand new medication, being aware of what the side effects are and what to look out for could be a big deal as well. So if somebody had been on the same medications for 10 years and suddenly they have 3 or 4 new ones, all with different side effect profiles, then, that could be an explanation for some new symptoms as well down the line. So anyway, not to be super negative, but if I had an emergency preparedness kit, which I'm working on getting a PDF to you guys about what that is, one of them would be a relatively updated, maybe every 6 to 12 months list of medications. The last time my dad was in the hospital, thankfully, he goes to the same hospital pretty much every time he has an issue, which is 2 or 3 times a year. And that hospital has a pretty much running list of his medications. But his primary care physician has an online medical record system with a patient portal. And even when he was really sick, he handed me his phone and said something like, "Go to the portal." And of course, I went in his phone and I clicked on the portal and it automatically logged in because he had saved his password. And then I had access to his most recent labs and his most recent medications. And so that was super, super helpful. So anyway, that's the medication pitfall. That's probably the biggest one. So the next one I want to talk about is appointments. So the first one is medications. I bet we can make an acronym out of this. So that's the M. The next one is appointments. And this is usually listed also on a discharge summary, usually towards the bottom. And it will list recommended appointments. Like I said, there's a pretty much standard recommendation to see a primary care physician within 7 to 10 days. Now, depending on the hospital system, it's actually pretty rare for them to make that appointment. So either the patient or a patient's family member or other representative will need to be reaching out to a primary care physician to help secure the appointment. Now, in a lot of different areas in the country, primary care physicians can be booked really far out, sometimes multiple months. And so the key is, when you're calling to get a follow-up, is to mention that it's a post-hospitalization or discharge follow-up and that there's an official hospital recommendation for a 7 to 10 day appointment. And usually that will kind of unlock a different set of appointments. If you just call randomly and say, "Hey, Mr. So-and-so needs an appointment in 7 days," and you don't say anything else, it actually might be difficult because you kind of go into the regular priority bin and might end up waiting for a while. And so, and it could be, if you're really trying to be proactive, is understanding what their policy and availability is, even at the primary care clinic. Worst case scenario, I have had some patients that decide to go to an urgent care or something else to kind of get checked on, especially if there's something else that the primary care was supposed to check on, but they weren't available, such as a wound, or, they needed a labs drawn to get a level on a medication or something like that. But just please know that most of the time, those suggestions in the discharge summary are not actual scheduled appointments. They're suggestions. They'll say, "Call Dr. So-and-so's office." So if somebody needs to go get some staples removed or sutures removed, it might say, "Follow up with Dr. Smith in 2 weeks." That's the suggestion. And if that appointment's not made, most of the time, I don't have any data on this, Dr. Smith's office is not calling to say, "Hey, you missed your 2-week appointment." A lot of these doctor's offices are so busy and so far booked out, the last thing they're doing is going and sort of prompting patients to call and get on the schedule. And so you do want to take a look at that. And the earlier the appointments those are made, meaning like calling maybe even before discharge, the better, because then those are set. You're not getting in a situation where you're calling and there's no availability. And, you kind of think of it from practical purposes. Well, if they say follow up in 1 to 2 weeks and that doctor's out of town for 3 weeks, I mean, you might be in a period where there isn't a lot of coverage. And in that case, you always want to ask if there's somebody else in the practice who will see the patient. Usually it's a better option than delaying the care and so forth. So check on there and secure those appointments. That would be the next one. The last one, there's probably a lot. I think I'm just getting tired because it's late and like right in the middle of me recording this podcast. I had 2, I'd say a category 4 and a category 5 meltdown with the twins. And so there's actually like a 3-hour gap between the first part of this podcast and the second part of the podcast. Because of that, they were at school today and selling items at their market days, and they both brought a lot of inventory and sold out on day 1 and it's a 3-day market. And so they both came home devastated and hysterical because they sold out and they were demanding all sorts of stuff that I was not willing to suddenly go to the store and get. So yeah, that was several hours. Anyway, okay, so I am back talking about this. So medications, checking on that, the appointments, that's a big one. Other more subtle stuff. So the next would be like, I guess I'll use the word S for surveillance. And that's knowing that there's a lot of times when you leave a hospital setting, some loose ends. And sometimes it's not all that clear, and I'll give you some examples. So one would be if there was a lab pending, like some cultures or something. I've had this happen where somebody drew a urine culture the day before someone left and then didn't have any follow-up to it. And, sometimes you need that urine culture to confirm that the bacteria are sensitive to whatever antibiotic is in place. And sometimes you won't know that. So you might leave thinking that you're treating a urinary tract infection, but then the antibiotic profile comes back, and that's sometimes doesn't come back till 2 or 3 days later to the hospital system. And then you're on the wrong antibiotic, and you'll know because the symptoms don't get better and the fevers might return, something like that. And to be honest, it is very difficult unless you have a patient portal to the hospital setting. Sometimes it gets down to literally calling the nurses station and trying to get a follow-up, but that can be really hard to track down. So that's one example. Another example would be looking for signs of infection. So any kind of incision or wound that happened as a part of the hospital course. So that even could be, if we're going back to our heart attack patient, if they had a heart cath and there's some incision over in their groin or their thigh, even if it's only 3 or 4 stitches, you want to have a plan for surveillance, at least for the first 7 to 10 days after somebody gets home, because that's when we're going to be higher risk for infection. And infections do take several days to show up. And so it's not, the incision is there on day 1 and 6 hours later it's infected. These things tend to take some time. And so someone could leave the hospital system and have a wound that doesn't look infected, and then 2 or 3 days later have something that really looks infected that had just been kind of brewing. And so if there's any skin break at all, especially in areas that aren't exposed. So if it's, the forearm or something that's easy to see, that's one thing. But if you're looking at something that's like on somebody's sacrum or their bottom or in their groin, or even areas that are just really aren't easy to see, some sort of surveillance of that at least once a day, either educating the patient, or in this case, a parent, on how to check it, or having a caregiver come, or home health, if they have home health services, which are great for monitoring things like this. That would be another good one. So the most high risk for being rehospitalized is the week after you leave the hospital, and then your risk kind of downtrends from there. And so it's very common to go home and have some sort of complication. And so you can't control everything. And of course, there are people that have to go back to the hospital for different reasons. But, once you got your medications mostly squared away and your appointment scheduled, the next is just what's the worst thing that can happen. And that's where we really don't, I think, do a great job in medicine. Once we've decided that patient is going home, I'm not sure there's a whole lot of sitting down. I think the discharge nurse maybe is probably the person that would be delivering this. Now, watch out for this, watch out for that. And in fact, I've seen in the last couple of years the actual emergence of what's called a discharge nurse. That's the nurse that's all they do all day long is go around and discharge patients. And so I kind of like that that's developed, because that is a special skill set, and there is a lot of information that needs to be shared to help reduce the rehospitalizations that maybe a floor nurse who's got 7 other patients doesn't really have the time to sit down for 15 or 20 minutes and talk about, surveillance of the wound or things like that. So other things that you would do for surveillance is medication side effects. We already kind of talked about that, especially if they're on a new medication, if they're on a new blood thinner. So we go back to our patient with the heart attack. They'll most often be put on blood thinners after that, especially if a stent was placed or they had some sort of cardiac procedure. Some of those blood thinners, the old school ones, Coumadin, require lots of frequent blood monitoring as far as like what they call the INR levels to track how thin the blood is. But most of the newer blood thinners don't actually require that, but it is a new awareness that patient is now on blood thinners. So extra careful with fall prevention and so forth. And I'm going to add falls in there now that I mentioned it. I mentioned the first week after you get home is high risk for rehospitalization. It's also high risk for falls. So recent hospitalizations is a risk factor for falls almost universally. Like, doesn't really even matter what the hospitalization was for. And part of that is because the patient comes back into the home debilitated. because they've been in the hospital laying in their bed. And so they might be in their same environment and think, oh, I can get up and go to the kitchen and get this, but their legs don't work the same. Their balance isn't the same. And so it's almost deceptive because their brain is thinking old habits, and I'm just going to get up and go to the bathroom by myself at 2 a.m. with no lights on. And I have seen many, 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 many repeated admissions for that exact scenario. So that's kind of the highest risk time as well. And so we do have a lot of patients who do have an adult child that's supporting them that is planning for the first week after they get back from rehab or from the hospital to come and kind of stick around. And I always think that's a good idea if somebody could actually pull that off. And I think long term, it saves a lot of time and effort because you're kind of covering the highest risk period and then tapering off from there as that person is getting stronger and more confident and kind of coming back to themselves. So I know I just spent about 90% of the time on medication and 5% on appointments and surveillance, but that's a good start, right? So you can think of MAS, medications, appointments, and surveillance. I think that's a good start to getting a handle on what do you do. And I really want to, and one of the things I'm thinking about focusing on the podcast, I think we do this a lot, but I think we could do it even more, is me sharing exactly what we can do that's like easy to remember and maybe not easy to do, but let's create some fun acronyms around it and make it accessible and make it something you could share with a friend who's, if you've got a friend whose mother is in the hospital right now, you go and say, okay, here's what we're going to look out for: medications, appointments, and surveillance. And make it something that's easy and practical to do. As far as just kind of circling back to what can be done while you're in the hospital, that's the best time to advocate, is like a day or two before discharge and asking these questions. Well, how many days of prescriptions are we going to get? And they'll say, oh, our default is 7. Okay, but the primary care physician can't see her until 14 days out. Do you think we could get prescriptions for 21 days just to be sure? Okay, no problem. And so it's that kind of just basic problem solving and anticipation I think could help save a lot of heartache in the long run. And then really taking so when somebody's being discharged, and this happens to myself and to my family, and I understand totally how this happens. You want to get home. You just want to get out of there, and the car is waiting. You're tired, you're hungry, you don't want to eat that next hospital meal. And, you maybe not even be all that present during the discharge session with the nurse. But honestly, that is one of the most important sessions you have. That is the last touch with that healthcare system. If there is a question, if there is something to wrap up, and having the nurse go and clarify or look in the medical record, quickly and get that answer, boy, you're saving tons of time versus trying to circle back and find them later. And so that session, as much as you do want to skip it and get out of there and just read the documents later, in my experience, the patients do not go home and study their discharge documents. I might know a couple of people like that, but for the most part, they end up on a shelf somewhere. Oh, that's another thing I was going to say. See, I'm glad I'm still yapping here. Is you have to save the discharge documents and, better yet, make a copy or two of those, because if you take those to your primary care physician, they can very easily just disappear. Like, you hand them to a nurse who hands them to the doctor who forgets to hand them back to you, and then you lost them and you try to go back a couple days later and nobody can find them, blah, blah, blah. Like, that discharge document is an important document to keep. That will have the medication reconciliation, that will have the diagnosis, it will have the follow-up appointments. Like, that is a really important piece of paper. And I would keep it from every part of the hospital stay. So if you get discharged from a regular hospital over to a rehab hospital, those are 2 different systems, 2 different discharge summaries. And so I would keep a copy of both of those just to be on the safe side. So see, I knew there was some other tidbit left in there. I appreciate you listening. I hope that was relatable, practical advice. If you know anybody who needs it right now, please do share it. And I will see you soon. Take care. Have a good week.